Let's finish this lecture series on Beecham and Childress's principle of respect for autonomy with the concept of informed consent. Here we'll talk about what informed consent is and then also look at Beecham and Childress's model for informed consent. We'll also return to the concept of informed consent later in the semester as its own little standalone week. So this is just more of a primer for that. I'm confident that you've heard the term informed consent before, but it's worth getting a formal definition. Informed consent occurs when sufficient information about a medical intervention is provided and explained to a patient to obtain permission beforehand before they receive a treatment. So the idea is that we want patients to make autonomous decisions for themselves, but one of the parts of that is that they have to have the knowledge necessary to make that decision for it to be autonomous. So Beecham and Childress distinguish two different acts that occur for informed consent. The first one is that information is communicated between patients and healthcare providers. The second is that the patient then authorizes the specific medical treatment. So information is communicated and then patients then make the decision and authorize either or refuse that medical intervention. As Beecham and Childress note, there are two different meanings within the healthcare setting when we use the term informed consent. The first one is ethical, a person's autonomous authorization of a medical intervention or participation in research. That is to say that we want people to make decisions on their own behalf because we think respecting autonomy is the correct thing to do. The second sense in which informed consent is used is to say that conformity to social rules of consent that require professionals to obtain a valid consent for patients. That is more like legal waivers to say that whatever happens, you consent. And so Beecham and Childress really want to stress that the former type is what we should be really concerned with, because we think that autonomous decision making is important for patients to possess. They say that the problem arises from the gap between the two senses of informed consent, that physicians who obtain consent under institutional criteria can and often do fail to meet the rigorous standards of the autonomy-based model. As you can see on the screen, this is Beecham and Childress's model for informed consent. It's broken into three different sections. You have threshold elements or preconditions, information elements, and consent elements. So based on what we were just talking about, how there are two different sort of steps in the informed consent process, the second section here, that is about communicating information to a patient, and then the third section is about the authorization of the patient to make their own decision for them. The first section is more about competence, which we talked about in the previous lecture. Here, we're just going to focus on the three sections that Beecham and Childress focus on, which are voluntariness, disclosure, and understanding. I'm going to go out of order of how Beecham and Childress present it, and instead just go with a sequential order of how they appear in their model. I think that makes more sense. So this idea of voluntariness is about being able to make an election free of control of another person or some other controlling condition. And Beecham and Childress say how that there are these three different forms of influence that can limit voluntariness. So there's coercion, which occurs if and only if one person intentionally uses a credible or severe threat of harm or force to control another person. There's persuasion, so a person must come to believe in something through the merit of reasons another person advances. And then there's just manipulation, which is swaying people to do what the manipulator wants by means other than coercion or persuasion. They also say how it's likely a form of manipulation in a healthcare setting is informational manipulation, which is to say that if you limit the amount or what information becomes available to a patient. That's another way of manipulating them. But we'll talk a little bit more about that when we get to the paternalism part, or the paternalism lecture later in the semester. So what are some examples of this? Think about patients or people who are paid to participate in a research study, how they can ultimately be vulnerable and their voluntariness limited because they don't really have any other choice, because they need the money or they need the benefits. And so Beecham and Childress talk about the Tuskegee syphilis study case. If you're not familiar with it, you can look it up in Beecham and Childress' book, or you can also pretty much Google it. It's a really famous case. But in that, the participants were paid for their participation, and they really didn't have too many better alternatives, and they were subjected to a number of harms that no person who would have been able to make a voluntary choice probably would have made. I can almost undoubtedly think that nobody would have made that choice if they would have had all the information. But still, the financial incentives and things like that can be a form of sort of coercion that forces people to participate in something or choose a type of treatment that they wouldn't normally choose. You could also think about familial pressures, insofar as if a family member is trying to pressure a patient into making a certain decision that's in their best interest rather than in the patient's best interest, that can be another form of influence that can ultimately limit voluntariness. I do like how Beecham and Childress have this line where they say, many suffer a decline in their ability to carry out personal choices because of physical impairments. So they start to lose physical abilities, but this decline in executional autonomy, meaning that they lack the ability to actually perform different activities and things like that, doesn't necessarily imply that there's a decline in decisional autonomy. So as we get older and weaker, and we aren't able to do everything that we used to be able to do, and now we're more dependent, our voluntariness has become limited. That doesn't necessarily mean that we now lack decision-making ability. So that's why they really want to stress that this is voluntariness in being able to make decisions rather than voluntariness in being able to enact certain desires or wills or things like that. Now let's move on to disclosure. So Beecham and Childress outlined 3 different competing standards for what counts as adequate disclosure to a patient. And as they remark, each of these have their own problems associated with them. So it's not as simple as just saying that you prefer one model or one standard over another. It's going to take some pretty critical reflection to decide which standard is the appropriate one in different circumstances. So looking at the first one, the professional practice standard, this is this idea that there is some customary practice within the field that determines what counts as adequate disclosure. So imagine that every time that somebody gets a heart transplant, everybody receives the same information disclosed to them. It seems like that would work, but there are difficulties obviously associated with this, because professionals don't necessarily all agree on what a patient should actually have access to. So is there really a customary standard that if there's an agreement among all these different professionals, I would be surprised. The majority of professionals could offer the same inadequate level of information, which is to say that if all the heart surgeons in the world came together and they agreed that this is the information that should get disclosed, that might actually be insufficient for what patients really need. But just because the heart surgeons all agreed on it means that that's all the information that any patient would ever receive. And that seems problematic as well. It's questionable whether physicians have developed the skill to determine the information that serves their patient's best interests. So being able to perform heart surgery doesn't necessarily mean that you have an adequate read on what's on what patients will actually need to have access to make an autonomous decision. And so in this way, it ultimately ignores or may subvert patients' rights of autonomous choice. The second standard here, the reasonable person standard, here we're supposed to conjure up some hypothetical reasonable person. And we ask ourselves, well, what does this reasonable person expect from us when we're disclosing this information? The problems with this one is that it's hard to actually define the concepts of what is material information or what is important information that a patient should receive, and it's also difficult to define what it means to be a reasonable person. The abstract and hypothetical character makes it difficult to use this standard because ultimately we have to project what we think counts as a reasonable person or a reasonable patient. And this gets back to what we were talking about in the previous lecture with competence and testing for it, insofar as we have this sort of bias to say, well, I think that this is what counts as reasonable, and if people aren't able to do what I think counts as reasonable, then they are incompetent. And the same thing works here. If we are projecting what we think a reasonable person should be able to grasp or would need to know to make an autonomous choice, we are ultimately operating on our own image of what we think reasonableness looks like. And so my reasonableness might be different than yours. And so now we are in a situation in which we are projecting what we would think we would want to hear to make us have an autonomous decision. But that's not necessarily the case for every other patient. The final standard here is a subjective standard, and this is the idea that the adequate information that a patient should receive is judged in reference to the specific informational needs of an individual person. And so obviously this is the preferable moral standard of disclosure because it's the one that's ultimately going to meet the specific needs of each patient, but it's also going to be really difficult to expect a healthcare provider to provide this in every situation. It's very demanding. And it also leads to this problem as before, insofar as we are trying to make a judgment about whether or not somebody has grasped that's going to be the next thing. That would be understanding. The issue here is that we are trying to make our own decisions about what counts as reasonable information to disclose to a patient, and how do we know that we've actually answered our own patients' questions that they have about it enough for them to make this decision. So obviously subjective standard is preferred because it's the one that's going to meet the particular needs of an individual, but it's also going to still be messy, complicated, and in many cases too demanding on a healthcare provider. But that is what Beecham Children have to say about it. Their recommendation is that we use the reasonable person standard as the initial standard of disclosure and supplement it by investigating the informational needs of particular patients or potential research subjects. So they're more hesitant to employ the professional practice standard. I think that this might be I tend to agree with Beecham and Childress here. Of course, I'm not a healthcare provider, so my stake in this discussion is a lot less than yours, but I hope you see the advantages of starting with the reasonable person standard and then providing additional information as the patient requests it. I think that is a good mix of strategies to ensure that patients are receiving the information they need to make an autonomous decision. The other feature of disclosure here that Beecham and Childress mentioned is one that we've actually encountered already in a previous lecture, which is this idea of therapeutic privilege. So when we're disclosing information, we're ultimately the ones who decide what information we think is relevant, which information we think is irrelevant, and so that is a pretty powerful position to be in. And so there is this idea of therapeutic privilege, which is to say that you might be legitimately, it might be, let me see if I can rephrase this better. There's a legitimate reason to withhold information based on sound medical judgment, insofar as divulging that information could ultimately lead to harm for the patient, like depression or becoming emotionally drained or causing the patient to become unstable. So if you remember the example of the case of the Navajo who do not like hearing about potential bad outcomes because they think it speaks them into existence. And I mentioned to you about patients who feel extreme anxiety about diagnoses. And so here, this would be another situation in which like therapeutic privilege might suggest that disclosing certain information or withholding it is perfectly permissible in these situations because they would cause harm to the patient. That's this idea of therapeutic privilege. Let's finish by looking at this last step in the communication section of Beecham and Childress's informed consent model here. So if a patient understands what we mean is that they've received information and that information is enough to inform their beliefs about the nature of a certain intervention, and then they can make an autonomous decision based on that information. So if they understand, that means we've satisfied the disclosure element here and we've provided this recommendation, and based on that information, patients have an understanding, and then they'll move on to authorize either the intervention or refuse it. But understanding is complicated by a number of different factors, and judging whether or not a patient actually understands the information, that is going to be quite difficult in most situations. Beecham and Childress sort of give us this list of different problems with understanding. The first one being a therapeutic misconception. This occurs where subjects may fail to distinguish between clinical care and research, and may actually fail to understand the purpose and aim of research, thereby misconceiving the participation as being therapeutic in nature. What they mean here is that imagine if you're invited to participate in a clinical trial for a new drug to treat a disease that you might have that is life-threatening, that there's no treatment for, and your initial thought is, yes, because there is no other treatment, I'm going to try whatever I can, and so this is going to help me. In reality, when drug companies and different professionals are doing clinical trials, the whole idea isn't to necessarily alleviate the current pain and suffering of the patients. Right now, this is just a trial. This is all about research. It's not about necessarily curing somebody's disease. It's just about collecting data. And if patients misperceive what a research trial is actually for, it can sort of give them this false hope and sort of impede their understanding. Additionally, there's this therapeutic optimism, which is when patients accurately understand the odds that participants will benefit, but are overly optimistic about their own chances of beating those odds. So if you say, well, this treatment carries significant risks and it's a very low probability of actually working, say like 10%, and a patient says, well, I'm going to be part of that 10%. That is therapeutic optimism. And although we hope that every patient is part of that 10%, we still have to recognize that if a patient is going into it thinking that they will be one of the lucky ones, that might indicate that their understanding of the consequences is not meeting the threshold that we would expect them to. There's also the issue of information processing. So the lesson is the need for better understanding of techniques that enable professionals to communicate both positive and negative sides of information, right? So I'm not going to understand all the medical mumbo jumbo that an actual healthcare provider will know. So how do you present the information in a digestible way for me and a patient that did not graduate from medical school or get a nursing degree? So how we convey that information, whether or not the patient can process it, that also impedes understanding. There's also the issue of non-acceptance and false belief. Beecham and Childress give us a really interesting case here in the text about a 57-year-old woman who was admitted into the hospital for a fractured hip, and in the process of assisting this woman, it was discovered that she also had cancer. And when the physician was trying to communicate that to this woman, she was just not going to accept it because she didn't feel like she was that sick. And she thought that only, cancer patients are sick, and so you have to be completely wrong. And so, no, I'm not going to authorize any other treatment for cancer because I obviously don't have cancer. So this is an instance of non-acceptance and false belief, which will also impact whether or not a patient can understand the information that's presented to them and make an autonomous decision based on the accurate information that you are providing them. And then finally, this issue of waivers. We sort of started out by talking about there's a difference between the ethical type of informed consent, where we really are striving to protect a patient's right to autonomy. And then there's also the legal side of informed consent, where it's just, hey, I need you to sign this form because that's what the institution needs you to do to sort of keep you from suing us later. That type of waiver practice ultimately doesn't get at the core of what we're trying to ensure for our patients' interests here. So many patients trust physicians, and a widespread acceptance of waivers of consent in research and therapeutic settings could make subjects and patients more vulnerable to those who omit consent procedures for convenience, which is already a serious problem in the healthcare field. What we're really concerned with here is that trust being eroded between the patient and the provider, and a waiver is a way in which it can avoid these tougher conversations to make sure that the patient still understands because they just defer to your expertise. So although we want patients to understand, and it seems pretty straightforward that if you have this conversation with them and they say, I understand, it's still important to be critical of what is actually happening in this interaction to ensure that the communication process is fulfilling what we are expecting it to. Recap what we've talked about in this lecture. So we first looked at informed consent, and we talked about the different ingredients it has, which are thresholds, information, and consent conditions. Then we moved on to look at 3 different features of Beecham and Childress's informed consent model. So voluntariness was the first one that we looked at, which is threatened by influences such as coercion, persuasion, and manipulation. Then we moved on to disclosure, where we talked about these 3 different standards of disclosure: the professional standard, where the professionals within the healthcare field say this is the expectation that a patient would want to know this information for this treatment, and we all agree, so that's what we're going to go with. Then there's the reasonable person standard, where we're asked to conjure up a hypothetical person who, if they are reasonable, would want to know X, Y, and Z. And then finally, there's the subjective standard, which is to say that the information is tailored to the specific needs of the patient. And Beecham and Childress gave us a suggestion to start with a reasonable person standard and then work off of the subjective standard as patients need more specific information to understand what the intervention is going to do. And that gets us to the third one, or the third feature of the model, which is understanding. And we were just looking at how understanding can be complicated for a number of different reasons. Finally, before ending this video, you might want to be able to answer this question before you take the exam, which is, why is informed consent so important for the principle of respect for autonomy? So remember that when you're studying for the exam.